Oh, this one's a fun one. Good. Let's see what we got here. Yeah, this is my disclosures. I defend these companies against fraud and abuse charges, and I don't own Inspectra in any way, shape, or form. This is a way of determining post-extractional oxygen. When I was a kid, we had blood gases, and we knew that that wasn't the answer, but it was better than what we had. We could look at the PO2, we could look at the PCO2 and the pH, and we could figure out what was going on very quickly. So we didn't have to search too far to know what we had to fix. Because remember, when you've got a blood gas that's screwed up, it doesn't make any difference what compensatory mechanisms you have. When that pH goes way up or way down, you've spent them. And so we knew we had to get off quickly and get going with it. And so what we really wanted to know, next we thought, well, oxygen saturation was going to be it. And that tells you what comes through your finger. But what we really wanted to know is how much of that oxygen going to the tissue is actually delivered to the tissue. And that's what's called post-extractional oxygen. And these guys use the name the TCO2. I don't like it because when you say CO2, everybody thinks you mean carbon dioxide. I would not have used that, but they didn't ask me. So this is an oxygen extraction measure. And so what it tells us is there's no invasive catheters. You don't have to calibrate. You don't need blood samples. There's no lag time, and there's no lactic acid test to have to do. All you do is clamp that thing on the thumb, and it gives you how much extraction is going on. So even in resuscitation, it will track the oxygen delivery to the tissue, and for this you don't even need a pulse. You do not need a pulse. So it's very quick and effective. And this thing replaced a bunch of efforts to try to do this earlier with devices that just didn't work. I was working in a pediatric hospital, and it was a mess. So cost effective. And there's a guy down in Miami that's the head of the anesthesia group for open heart surgery named Martini. And what he did was he put this evaluator on your thumb. And if you're not extracting 75 or lower, meaning you're hyper-extracting the oxygen, he doesn't transfuse them. He saved a bunch of blood by using that. And it's turned out over the time it's worked. It would bother me to send a guy with a cardiac repair out with a hemoglobin of 8, but they did that. And he showed that it didn't really make any difference, that they could build their blood back up. So that's huge in terms of risk of blood transfusions and cost. So we're going to talk about the STO2, looking in the peripheral muscle, and how this might help us here. Now what this shows is that there's the artery which we used to stick for blood gases, and the microcirculation between them where the capillaries are delivering the goods to the cells, and then you got the vein. And so we used to put a catheter in the pulmonary artery, catheter in the pulmonary vein, invade them, calculate. It took about, I don't know how many hours, but meantime, the guy's laying there trying to die, and that never was very effective as far as, and we got lines that can get it infected and a few other things. So this thing is the hemoglobin oxygen saturation of the microcirculation. This is after it's delivered the goods. So the O2 sat measurement is in the arteries. The venous blood is in the veins, the vena cava. But what we really wanted to know was, what is the tissue doing about it? So the hemoglobin oxygen saturation of the microcirculation is what we're worried about. And that's what this shows. And this is where the oxygen actually goes to the cells. So it's a measure of tissue oxygenation, and is a very sensitive indicator and an earlier indicator than any monitor we have of tissue perfusion. Now, here's a situation in which you got a young guy that got shot through the scapula. He comes into the shock trauma unit, and you got all sorts of things here that show you. But the yellow dots are is the O2 sat. You got the blood pressure in a blue diamond, which shows that he comes in and his blood pressure is pretty high because he's obviously shook up about it. And the heart rate's the red dots there going across, and then you got the hemoglobin looking at like a red diamond, and there it is down there in the bottom line where he comes in and he's got a 12 hemoglobin and it doesn't look to change. However, look what happens. The guy comes in and he's obviously got a hemothorax, and so they put a chest tube in him and they start giving him some blood back. And here's the STO2. Now, anytime you start extracting below 75, that means that either the volume is not there, the red cells are not there, or the squeeze is not there. And most of us can look and figure out which of those three things it is. And sometimes it could be two of those things. And in a guy with a bullet wound, but the hemoglobin doesn't show that. What this shows is that initially he's doing okay. His SAT comes in initially at about 50. That doesn't look too good, or 60. And then he goes up to 80, but look what happens. Down, down, down. They've already given him 500 back, so they go, uh-oh, we better do some more transfusing here. There's 200 ml, and he gets 600 ml of crystalloid, but he's still going down. So, in fact, that the oxygen sats are good, the blood pressure isn't all that terrible, hemoglobin does not show any drop, it continues to have blood, and they're putting blood back in him. And now that they sort of get a hold of the resuscitation, this man then finally starts to get better. And as the lung inflates and tamponades the bleeding, this auto transfusion is no longer necessary. He comes up above 75 and he's stable. But all the parameters we normally monitor in ICU, blood pressure, pulse, O2 sat, did not show the jeopardy that this guy was receiving. And one of the problems we've always had is overdoing it. Everybody that comes out of ICU gains 10 pounds of water or more. And you guys who have the misfortune of doing that all day long know that for sure. So here shows that the O2 sat wasn't the clue, but the transcutaneous oxygen was a big tell. And that's those red arrows showing that it says we got to continue to do more. Now, how do we know that this is telling us what the body's message really is? Why are we measuring in the thumb anyway? And so what they did was that they did some perfusion studies looking at what happens. And they looked at the muscles in the hands, the liver, and the gut. And during shock, blood flow is going to get shunted, and the core organs are going to drop, as well as the peripheral muscles, because the body's trying to fix the heart and the brain. We don't do well with those injuries, so Mother Nature knew well ahead of us that that's what you got to preserve, and you then sacrifice blood flow to the other areas. The thin arm muscle group on the thumb is a peripheral muscle, and we look at this because we can do non-invasive monitoring, and as that last example showed, we can find out what's really going on. Now, the interesting thing is that the thin arm eminence is not much affected by age, gender, edema, adipose. By the way, in the old ones, if you were a black-skinned person, it wouldn't work at all. So it's not, you can have dirt, you can have blood on there. If you're hypothermic from some of the resuscitations we do, it will still measure accurately. So it's really bypassed a lot of the things that we here it goes, the hypothermia doesn't bother. That's sort of fallen out of the luster, you know, it got a lot of press to begin with. And all this thing shows is, when you start putting catheters in all these organs, that every place we're measuring, the thumb being one of them, they're parallel. So that this is the body's proof that what we're doing there in the liver, the stomach, and the skeletal muscle, all are parallel, which means it's really monitoring what's going on inside you, and without a lot of hoopla. So liver and stomach during shock and resuscitation, the thumb is telling the truth for all of those organs. And so the normal STO2 shows this capillary bed on the thin arm eminence. And the high probability that the oxygen is good, if it's at 75 and above, then you've got plenty of oxygen that you're getting without having to hyper-extract the oxygen. So it tracks with the core oxygenation as we've seen. If you've got a low STO2, then it parallels the organ perfusion, and it's an early indicator, as we saw in the one example, of low core organ oxygenation. And that, of course, is a worrisome sort of thing. So you saw how it corrected. So let's take a look at the hypoperfusion. And this came from a 380 severely injured trauma patients in various sites throughout the country here. And this was due to hemorrhagic shock and volume loss. And so the endpoint that they chose was organ dysfunction and death as the endpoints. Not very nice deaths. So in the first hour, if the StO2 is below 75%, that's pretty serious, as that gunshot wound to the scapula showed. And so you really got to sort of do quick things, which we talked about in the ARDS, to fix it. The quicker the better, because it tends to be self-perpetuating. So if you get above 75%, that tells you got adequate perfusion. That means squeeze, volume, and red cells are all doing okay. So the StO2 functions well as base deficit and lactate, indicating hypoperfusion, because as you know, lactic acidosis says you're not getting enough tissue oxygen. So you can do a trend line by putting this thumb unit on an individual in shock and just monitor what goes on. These batteries will last 8 hours, and this thing comes with a rechargeable battery that you just pop this thing in a little carrier. In fact, I brought one to, after we get done with the last lecture, we'll let you fool with it a little bit and see what happens. But anyway, it's a trending line. And so anytime you're above 75%, that's good. And you can see right here when it's low, you got to look for hypoperfusion, and you're going to be putting intravenous fluids and maybe blood in, depending on the circumstances. Now, when you're seeing that the level is rising toward normal, you can then continue to do what you're doing until you get to that 75%. Now, when you get above that 75%, showing that there's less extraction, and that means you get more volume carrying it, then you can just sort of put things on hold. This is one of the few things that ever allowed us to not drown people in critical care, because it is a problem, and I'm just as guilty of it as everybody else. And then if it starts taking the dip again, you got to go back and look for mainly more bleeding and what am I missing. And so a little more resuscitation, and the patient's then out of the woods. So how do we use this stuff? I went to Omaha, Nebraska. This guy had written a paper about it. I'm one of these guys that sometimes calls the authors and sometimes visits them. And this is a young, tough-looking guy that ran a trauma unit out in Omaha. Boy, were they set up right. And he got a lot of crush injury, shock trauma, and he was a vascular surgeon as well. And if he had a kid that had a crush injury to the pelvis in a tractor accident and there was a question of limb compromise, he would put this machine on the feared side of injury, and if it started getting low, this thing would beep, and he'd come in there and do a Fogarty or do something to improve the blood flow. He even used it on limb monitoring. And they don't even say anything about that from the company that makes it. But that was just like Martini down there in Miami saving blood transfusions, looking at what the body thought about the adequacy, because we all know the body is always smarter than Pell for years. But here's another situation, compensated hemorrhagic shock. So this was an individual who came in. I think this was a lady who was riding the moped and sort of got whacked. And so she comes in the ED, and here again you got the heart rate in the red dots right here. She's a little excited, but not much. It's just above 100. And it doesn't really change much. These blue diamonds here are the systolic blood pressure. And it doesn't look too bad. Now it starts to take a little dip down here, but look what's preceding it. Here's the value of 70, which they don't even have shown here. But something happens, and in spite of the good blood pressure, this thing's taken a trend line down. So anyway, they take her to CT. Now we all know what is going to happen when you take somebody to CT. Of course they're going to go into a disaster. Hell, when I trained in Indiana, more people died in X-ray than in the ICU. And that was at the General Hospital. I'm sorry, Indiana, but it's the truth. And so, as usual, she looks good, everything, but this trend line starts to dip, and they sort of ignored it, and look what happened. Bang, she goes to CT, she's now unresponsive. So they had done the FAST test. This is an abdominal scan using an ultrasound, okay, looking for ruptured spleens and stuff, and they didn't find anything on 2 different ones. They've given her 2 liters of crystalloid along the way. Here's the hemoglobin at 12. It doesn't look too bad. And it really didn't, they didn't even bother doing another one. And this is what's called base deficit or lactate. And what this really shows is it's really not all that abnormal. But what starts to dip here is you got a real problem. So they did a second FAST test because they said something's got to be going on in the abdomen. And guess what? To the OR for splenectomy. But in spite of the vital signs being pretty good, and here's the O2 sat, the yellow squares, it never really did show much. So this is an early warner of let's go back and reevaluate this patient in a busy shock trauma unit. And so they then quickly started giving her some packed red cells while she's getting ready to have her spleen lifted. So it's a real help here. And what this shows is that in spite of all these good numbers, and this thing looking good initially, then right here we take a dip preceding any vital sign change, and a real dip here, and got back with our resuscitation mode, and this lady made it out of surgery. And here's the 75% line that says you're getting in trouble. And of course it occurred just before she's sent to the CT. But she survived, and everybody was happy. And this just simply shows this staging here, where once they get above 75, they quit giving the cells and tie off that spleen, you got a good deal. So all these are examples of the fact that regular vital signs miss the bleeding that we saw this example of. And we've all known that the hemoglobin has lagged for years. As a house officer and a GI bleeder, we all look at it and say, well, that isn't too bad, but the guy's got a tachycardia 160 and a falling blood pressure. No. Go back and do your job. This is a person that was found down. And in my county of Pinellas County in St. Petersburg, our paramedics do 540 transports a day. 540 transports a day. What do they say in the computer world? OMG. That's how, and that doesn't count the ones they see and give a dextrose to or whatever. This is transports. So they're really quite used to this stuff. And here's a guy that was doing pretty poorly. He comes in, and here's his transcutaneous oxygen. It's almost non-existent. So they do some things, and they're giving him norepinephrine. They're trying to get him better. And here's the 75% line. You can see that initially they get a pulse and a blood pressure. The O2 sats were kept high because we're giving him oxygen, but the tissue says I'm dying from lack of perfusion. They gave him bicarb, probably because they assumed that he had a lactate level. Here it is, 5.5. That's high. And so they gave him bicarb, but this man did not survive resuscitation because he'd been down too long. In Pinellas County, I haven't missed, Dr. Paula can maybe help me with this because she's on the transport board, but the average response time for 911 was 2.5 minutes. They vector them to the neighborhood based on computer statistical probability. It's unbelievable how good that system is. Very expensive too, so I don't think it's going to be around too long. Not like it was. Okay, so again, when you look at all the vital signs, things that we're normally counting on, and when you start seeing this guy take a big dip, and you start having to reconsider resuscitation, this is a more rapid monitor of all these things. I won't even get into all this stuff because a lot of it's sort of repetitive. What this shows, however, is what happens when you give a pressure. Now, I don't know about you, but I grew up with, when dopamine had just come out, we used to use lethal fed. You all know what that was. And that's why we named it lethal fed, because nobody survived it. And we always wondered, what's the body going to do? If we gave a dilator and they got hypotensive, then they volume loss. So we bolstered them back up, and then we would administer a dopaminergic type drug or nitroglycerin again, something. But we knew that if they dropped, they were hypovolemic, and we really had to quit that until we could decide. Well, here's a situation in which they had some bleeding, and you just come back from the OR, and look right here. This guy's blood pressure, let's see which one this is. The diamonds here starting to take a dip, so they said, well, we better do something. We're going to give this guy some vasopressors, and here's lethal fed, one of my least favorite, and then they got vasopressin here. Vasopressin is the most potent coronary constrictor known to man. That's why it wasn't too popular. We used to use it in GI bleeding because it's a vasoconstrictor, and it really helps the GI bleeders. But it can aggravate the heart. Well, when they tried using these pressors, the body said no. And look what happened here. They start the drug, and immediately, and they go to 8 milligrams. That didn't do it. They gave more, 16 milligrams. That didn't do it. So now they're backing the lethal fed off, and now they're down to 10 micrograms, and they start giving the packed cells, a liter of ringers, bunches of liters of ringers. So the crystalloid, the volume replacement is being done here, probably because the OR thought they were behind. And once they started giving the packed cells, that was what the body really wanted. So then they started backing down on the pressors and stopped them. And the vasopressin continued and really was well tolerated after they volume and red cell repleted this. So it's telling you that the body will answer our questions about don't give me that drug by simply having this simple monitor put on. So it's an early detection of hypoperfusion. It's an important tool in helping resuscitation. And it really works in the most adverse of circumstances. So let's take a look here. What if you got a low volume? You're going to look for hypoperfusion, and you're going to give IVs if clinically that's what you think. And then when it starts falling again, you start to go back and you look for other problems, mainly bleeding, to tell you that. So hemorrhage, new or ongoing. Non-hemorrhagic hypovolemia from a variety of reasons. Cardiac dysfunction. We know that some people who have these disasters have a heart attack during that. We just don't always look for it, but we learn pretty quickly if the guy's not looking pretty good to get an EKG while we're going through all this and do something cardiac to try to help the situation along. Pulmonary dysfunction we don't know about, and I couldn't find any literature that says that. But what we know is that in people that are chronically hypoxic from COPD, they start making a lot of 2,3-DPG, which is it allows the hemoglobin to dump more oxygen to the tissue. And we know that this is a focal change. It depends on the tissue how much oxygen you get. But I couldn't find anything about, and here I'm the pulmonary guy giving this lecture, I don't know what to tell you if you got terrible lung disease. But in shock trauma, and a lot of these guys, lung disease is not a consideration. But I don't have an answer for how the blood gases might interfere with this. And when I talked to some guy in the company, they didn't know either. Compensated shock with peripheral vasoconstriction. And so what will happen is if the person is clenching their fist or doing something like that, it can foul up the value. And then when we saw what happened with vasopressor administration, if the body doesn't like it, mainly from low volume, it's going to tell you pretty quickly. Flexing and clenching the hand with the sensor on. And then pre-existing conditions. If you got a bad artery going to one side or the other, you got to change your testing site. And then if you got real high levels of PEEP, I've never been a fan of PEEP, I'll tell you that right now, ever. I've seen too many people get hyperinflated lungs on a ventilator and nobody knows why the peak pressures are high. And if you take the PEEP off and put your hand on the chest, instead of doing this, you sort of find this even 5 centimeters. So, and that's because the COPD lung has much less surface area to absorb and a smaller blood supply. So if you got a dry person or you got bad COPD, real high levels of PEEP are you're pushing air into the lungs and keeping it there, and it drops the central perfusion. So backing off on the PEEP is one of the things we would do. Again, you can see how with your clinical knowledge applied to the patient you're looking at, any one of these things on this checklist, you'll be able to figure it out, okay, without having too tough a time of it. So, and then others, who knows what that is. So high values, about the only thing that will cause a high value is shunting, peripheral shunting. And so if you've got a person that's on peripheral vasodilators that dilate the periphery, that may change what the STO2, it may go from 80, which is probably the normal value, up to even as high as 90. So when you get a high STO2, systemic vasodilators and a cardiac output, if you got an AV malformation or an AV fistula, it'll probably be a problem too. And then, of course, sepsis, where you're getting shunting ahead of the capillary and impaired oxygen utilization of the cells, but when you're measuring the microcirculation, it isn't getting to the cells, and so you're measuring a bigger value. And then spinal cord paralysis, where you get a spinal shock. And of course, you know, the autonomics just sort of let go when that happens, and you'd be able to figure that one out from a neurosurgical standpoint. And in portal hypertension, because you have routes around the central circulation where you get shunting through the lungs, you get big veins, the esophageal varices, even in the hemorrhoid plexus. This can be a problem, so severe liver disease. And then drugs like nitroprusside can be a problem. So this sort of tells you what to look for. Now, by the way, it does not work in hemoglobinopathies. So if you've got a sickle cell guy in crisis, or a girl, or something like that, abnormal hemoglobins, because this is actually a measurement of the configuration of hemoglobin, this will not be an effective monitoring tool if you got a hemoglobinopathy. So, in summary, this little device here, and I brought one, measures the tissue oxygen at the thin RM, and it measures extraction. If you got a low one, you got to look for this big three: volume, red cells, and pump. And the high one is most commonly seen in a high cardiac output like thyroid storm, or in systemic vasodilator response. And there's a bunch of the references here about that. So I just want to point out that this thing costs $8,000. And this company's a tech company. They don't know how to sell this machine. That's why I'm doing this. And all you do is clamp it on the person in shock and see what happens. It'll tell you the hemoglobin level, and it'll also tell you what the post-extractional oxygen is. Anything 75 or less, you got to do something quickly, because the tissue oxygenation is not adequate. And it's remarkable. This is the deal we looked for 50 years ago when Felice and he was swearing in Italian and I was telling him bad jokes. And we wish we had this value here. They got like a permanent monitor that you use in the ICU, and a guy you're going to have to look at a long time, that it costs $31,000. But I kind of like this one, because all you do is clean it with isopropyl alcohol. Do not use bleach. Do not use any other cleaning agent. Isopropyl alcohol only. And all you got to do is swab this thumb piece that's the little black thing right there. So what I'm going to do is get into my next lecture, but when we get done in a hurry, you come back and try this on yourself and fool with it to see how good this thing is. It lights up pretty quickly.